ounce of prevention is truly worth a pound of cure. What we're seeing repeatedly in metabolic disease is that you require just small tweaks to prevent disease, but huge effort to reverse it. So to be to be proactive in our approach to preventing disease is an incredibly powerful tool.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. This topic is a personal research interest of mine, is a personal clinical interest of mine. And I am very happy to have two colleagues who have made this as their career and research focus as well, and are working in premier academic health organizations and institutions in the United States. Pleasure to have Jaideep and Romit with me. Dr. Jaideep Patel is a preventive cardiologist at Johns Hopkins. He leads the initiative called SACHI, or if I haven't pronounced that correctly, you can correct it to the audience, Jaideep.
Yeah, SACHI sounds perfect. Yeah.
SACHI or SACHI through the Johns Hopkins Sicarone Center. And then I have Romit, who is a preventive cardiologist at Mass General and is the principal investigator for our health study, specifically looking at the genome-wide contributions to early onset of heart disease in South Asians. And Romit, if I have not described the Our Health study properly, then you can correct me as we discuss more about the topic. So with that introduction, welcome to both of you. Thank you for your time. Thanks for being on Parallax. This is going to be a great episode. I've been looking forward to it. I know been trying to orchestrate this for a few weeks now, so I'm glad this is getting done. So I'm going to start by asking you, Jaideep, what prompted you actually to, to study this population the way you are, and what prompted your interest in the space?
Yeah. It's almost, that's like a loaded question. I think this is probably the same for most of us who come from South Asian families, is that a lot of this was rippled through my family when I was younger, and that's sort of all that I knew. I had the opportunity, and very lucky, fortunate to live with my grandparents who had coronary disease, high blood pressure, diabetes. I would always sort of hear these conversations in the background. And I think for me, the one thing that sort of pushed it the furthest was my mom passed away of a heart attack, actually. And she was in her mid-50s when that happened. I was a first-year intern in medicine at that time, which really sort of then stoked the fire to say, this is maybe something that I'm interested in doing. Obviously, I think for me, the first step was cardiology. I got really lucky. I had an opportunity to do some research with the Cicerone Center. So some of the original research that I was doing at that time looked mainly at family history. So it was self-serving, if you will, to say, is there some family issue that is going on here that we need to sort of look into? And then I think also serendipitously rather, after the Masala study was launched in 2010, they had come forward to the Cicerone Center in 2014, I believe, and said, hey, we have this data set. Is there anyone here who's interested in sort of using this? And I think, that was right up my alley, because I remember around that time thinking it'd be really nice if we had some South Asian data. We had very minimum, or all you would sort of hear is these review topics of high prevalence of diabetes, high blood pressure, dyslipidemia, et cetera. So from that has sort of fast forward now has sort of led us to using sort of doing more research into the use of things like coronary calcium, understanding risk scores, and has really sort of spurred the advent of what we do now at Hopkins at the Cicerone Center with the South Asian Cardiovascular Health Initiative, or SACHI clinic, which is more for patient facing, if you will, saying it's nice that we have all this data, but we've got to apply it in some way. And so that was the nidus for the clinic. which has now sort of taken on a different evolution. And more recently, we've sort of been able to get out into the community and sort of spread the word as well, which has been a nice change. And I think for me, the satisfaction of doing what we do is now that we have sort of mentees that are coming forward and saying, "Hey, we're interested too." Where this was sort of a blank slate, we've been able to create something, and I'm sure Romit feels the same way because I know he works in the community also. So it's really nice to have people who are equally as excited and interested about it, who really want to try to push this field forward and try to make a difference for the communities that we serve.
Yes, Romit, the same question to you as well. What prompted your interest in the field? And I think, well, congratulations on putting the Our Health study together. I think it's the first of its kind in North America, if not the first. I think the genomic component of our knowledge has always been lacking when it has come to the study of South Asians and heart disease in South Asians. And so I think what Our Health study is doing is novel.
Thank you so much. And Jaideep and I have had the opportunity to talk about this before, and it's such a powerful story. Similarly, in my family, there have been similar stories, but the pathway that actually led me here and looking at the genomics was actually a different path. Thinking about cardiovascular disease more broadly, we have known that heart disease travels in families. We've known this since ancient times. In fact, probably better in ancient times because the dominant form of heart disease was probably familial hypercholesterolemia at that time. But we've known this for a long time. And even in the 1970s, 80s, 90s, as we started getting a handle on some of the genomic forms of familial hypercholesterolemia, the vast majority of heart disease was not explained. And so we said, gosh, could it be true that only 1% of coronary artery disease, of MIs, are explainable through genetics? And something curious happened right around that time. There was a major advance in both sequencing technology and in computational technology that allowed us to look at the whole genome at once and not think of Mendel's P's and think of one variant meaning one trait, but instead think about genomics as a science of probabilities, of risk increases and decreases that can be summed together and multiplied as dosages, and we can get polygenic risk scores. That was such a tremendous advance because it began us thinking about not just one gene causing one disease, but a disease, or the end point of a disease process, being the result of maybe hundreds, thousands, or even millions of different pathways that lead there. And so when I started in cardiology training, I was an adrenaline junkie. I was like, let's go to the cath lab, let's go to the CCU. And I found myself chasing this disease, coronary artery disease. But every time I got to the CCU with it, I thought to myself, this could be prevented, couldn't it? Well, maybe I could have prevented it if I'd prescribed a statin. But then why do some people have high cholesterol? And then coming back into the pathophysiology. And it comes back to that first risk factor, the things that we're born with. Having said that, as you alluded to, the question of South Asian metabolic disease, South Asian cardiometabolic disease, which I'd like to get into it at some point. Like, why is it different? Is it different? We're all so similar. We're 99.9% similar, right? So are we different? That question really resonated in my mind. And I said, there really aren't ways that we have to disentangle these things. In the past, and we should talk about the Interheart study, we should talk about how these things got going. But we were told that South Asians just have higher rates of obesity, of diabetes, they don't exercise as much, they don't eat well, and that's why. There's nothing else to look for. But we had already seen the example of coronary disease as a whole disprove that kind of thinking. That we had said, we looked at the genome, there's only like 4 genes that cause familial hypercholesterolemia, there's nothing else to look at. And so now we are blessed with imaging technology, computation, genomic technology that are all allowing a type of investigation to say maybe premature disease and groups that have high rates of disease are worth investigating, not just because we're going to help South Asians, but because we may be able to discover things about heart disease, diabetes, obesity, coronary disease in today's environment that might help everybody. So the question, the debate really of lifestyle versus genetics, which I think it should always be not a debate, but a discussion of how they weave together. That's what kind of brought me into this field, thinking that there may be an opportunity with the newest technology and investigative techniques.
Yes, I mean, you said lifestyle and genetics, and weaving of the lifestyle with the genetics, which is epigenetics, which is your combination of epidemiology and genetics, which leads to what we know as coronary disease. And you bring up a provocative point, which we can talk about the Inter-Heart study and Dr. Yusuf's contribution, who actually has now come to a point where he thinks that the onset of heart disease in South Asians may not be premature. I mean, we've published these data from India through the ACC's Pinnacle registry in India, called PQIP, where, just like other studies, we've shown that the onset was a decade younger in South Asians compared with Caucasians. And you have the principal investigator of some of this early work in Dr. Yusuf saying that he's probably started to question whether the onset is truly premature in South Asians. Are we different? Are we really different? Or is it, look, I know our diets are different. I know we are not as physically active as maybe some of the other ethnicities are, or races are. And our lifestyles are different. Most Indian families, the idea of entertainment is watching cricket or watching Bollywood. There are those differences. And then certainly our diets are completely different. When I started food logging now about a year and a half ago, I realized that most of what we eat is carbohydrates and fats, and the amount of protein is very less, even though, lentils are classified as protein. They aren't truly protein. So I'm going to ask this question to you, Romit, and maybe Jaideep, you can chime in. Are we truly different, or what's going on here?
I think that one thing to remember when we're talking about any type of disease across the human race is that we are far more similar than we are different. Far more similar. And that's always really important to remember. So what that means when we say we're far more similar is that life's essential eight, the classic methods of prevention, these things work in South Asians just like they work in other people. The question about difference, in my mind, is once again about probabilities, right? Predispositions. What we see in South Asians is routinely lower BMIs, lower waist circumference, higher metabolic dysfunction. We see the particular lipid panel disruptions, that low HDL, high triglyceride, often high ApoB. In the Inter-Heart study, for instance, South Asians had lower LDL but higher ApoB, right? So those are typically described as these tighter, denser LDL molecules, but really I would just describe it as a higher ApoB. So there are distinctions, there are slight differences that might be manifesting disease at earlier stages. I agree to say that South Asians uniformly have coronary disease that manifests 10 years earlier is a dramatic overstatement. We don't have the data to say that, aside from the fact that South Asian itself is a geographic distinction that speaks nothing of the intense cultural, historical, dietary, physical activity, genetic sort of silos that exist within South Asia. Within 1 square mile in Bombay, I bet you will find many different silos of people, right? And so that's where we have to talk about, yes, recruiting to studies, looking at people's ethnicity and background so that we are able to grasp the diversity of variants. And then when we look at the pathophysiology, we'd be able to say, yeah, look, this one group had this dysfunction in this area. And that actually is true. We could treat that type of pathway in all people. I'm not saying that we're different. I'm saying that by looking at the diversity of humanity and the ways that this disease develops, we can better understand the disease in all its manifestations across all people. I'll let Jaideep take it.
I would echo everything that you're saying, Robert. I don't think we're different in any ways, and there are certainly finite or minute little things that may very well predispose us to having a disease manifest sooner. I think, things like, I'm trying to remember the name of the study, but there was a recent sort of in Nature that talked about the genetic basis of earlier onset diabetes or progression to diabetes in South Asians. So maybe there is some beta cell dysfunction and insulin dysregulation that happens sooner. Is that driven by environment and diet and physical activity? Most likely, like if you sort of were going to play the odds that way, considering that most people who develop diabetes later in life have some sort of dysregulation of the things that they're doing, such as physical activity and other risk factors, high blood pressure, et cetera. I think if you look at things like hypertension, for example, we know that about a quarter of the population by the age of 50 will have higher blood pressure, whether they want to or not. That's just sort of who we are. And it's a question of sort of identifying it. Good studies actually from Romit and his team with the UK Biobank has shown that maybe South Asians develop blood pressure a little bit higher and it takes off on a steeper curve, if you will, up front compared to other Asian groups. Maybe there's some, finite differences there that need to be explored that we just don't understand yet. And so maybe manifesting coronary disease sooner, it may be very well grossly sort of overestimated. I will say, and this is maybe forthcoming, but there is data coming from the Dilwale registry from a group in Texas showing that maybe the presence of coronary calcium happens, or at least truly detectable for the majority of South Asian men, usually by the age of about 55, 60. And that's sort of in line with white men. That's sort of what we see in general, if you sort of compare to other big groups like ERIC and MESA, for example. So I think that speaks volumes to the point too, that if it is developing sooner, then are these other little finite things need to get checked off earlier? And that's where this sort of aggressive prevention and screening sort of comes in, to say maybe these are the things that we need to be looking for. But by and large, to Romit's point, Life's Essential 8 sort of covers the general topics that we cover as well, that much of this is preventable. And many of these things make a large difference in the grand scheme of things as a sort of byproduct, because we don't necessarily have a lot of South Asian sort of outcome data per se. We know that, like, we had done a study looking at Life Simple 7, for example. So if today all three of us have a coronary calcium score of 0 and you maintain good habits by Life Simple 7, at 5 years, the likelihood of a 0 calcium score is close to like 90%. So I think that speaks volumes, knowing that when you sort of look at the quote unquote warranty period of a calcium score of 0, for example, in other races, where more often you're saying you could probably wait 7 to 10 years to repeat a calcium score. We know that, for example, in diabetics, they say if you're going to hold off, the warranty period, if you have a calcium score and you're a diabetic, we say maybe you can hold off for 3 years, repeat a score in that scenario. That's sort of a certain specific population, but I think parallels what most people consider as a high risk population, just as if you would say maybe South Asians are as well. But sort of going back to the original question, I think we're all the same.
I think one thing that we do need to look at is the development of these risk factors as well for earlier onset. One of the advantages we have as cardiologists is that we get to call everything cardiology so long as the end point is an MI, right? But the reality is that, a lot of the things that are worrisome about South Asian cardiovascular disease begin a lot earlier, upstream, right? And that's sort of what we saw in Interheart as well, right? So is the abdominal adiposity, we know that fat distribution and obesity level are highly polygenic and genetically inherited in nature. We've known that since the 1960s in Scandinavia, when we were able to show that that body habitus is highly heritable. We know that likelihood of type 2 diabetes is highly polygenic and highly inherited. We also know we're beginning to blur the distinctions between type 1 and type 2 diabetes, right? That there are versions of type 2 diabetes that really present a lot more like type 1s, right? And we used to say that, the heritability of type 2 diabetes is much more than type 1. We're beginning to learn that there's actually strong heritability of type 1 as well. So these and as well as blood pressure. Right? We've learned so much about blood pressure looking at, for instance, African Americans and the progression to end-stage renal disease. We've learned about the genetics of that. So each of these have their own genetic inheritance, right? And then you say, gosh, well, the risk factors are manifesting earlier with fewer, with fewer, or, with a lower BMI and fewer other risk factors. So then you say, could it be that the predisposition is just slightly altered? And would that be able to tell us about the development of coronary disease and how all of these things are linked? That's an incredibly important question in today's day and age when, CKM, the cardio-kidney metabolic disease, is really the entire reframe of cardiovascular disease that we're talking about through the American Heart Association.
Yeah, no, excellent point, Sam. I'm gonna sort of these are incredible points. These are incredible discussion points. I am going to present to you a case study, and the patient is me. So I have the privilege of the riches of two preventive cardiologists at leading academic health centers. So I am your patient. I'm 42. I recently had my calcium score at 0. My LDL is in the 50s. My HDL is 68. My total cholesterol is like in the 1 teens. My triglycerides are in like 50s or maybe 45. My LP little a is normal. My BMI is 22.3, 22.4. So I want to not have coronary calcification in the ensuing 5 years. So what do you think I should do moving forward? Because part of me thinks that no matter what you do, calcification of the coronaries is part of the human aging process. So correct my inherent flaws in this thought process, and what can I do differently, or what else can I do in addition to what I'm already doing to prevent calcification in the ensuing 5 years?
I'll just ask one clarifying question. Are those treated cholesterol levels or no?
I am on no medications.
Impressive.
0 medications. I take 0 pills.
This is Jaideep's area of specialty, so I'll let him take it away.
I agree. I think this is absolutely impressive, and you are a standout patient, and we should just parade you around as the model of health in clinic. I guess, so a couple of things. So you mentioned LPA. I like screening for the ApoB100 as well, because I think that is a different level of risk as well. The LPA, sorry, what was the value? I forgot. I didn't catch that. It was in
the 20s. I'll have to pull it up to see, but it was like 28 or something.
Yeah. So that's great, because then, that's an atherogenic particle that we're not necessarily dealing with. 50 is in theory the line in the sand where you start seeing the risk of atherosclerosis go up. So although you sort of can see it within normal limits on some of the lab panels, 50 for me is sort of where you draw the line. HDL is in a good spot, and for you, I think that's impressive, knowing that most South Asian men have low HDL. And I think the theory behind that is that the particle is dysfunctional. So sometimes in my patients, what I'll check is a surrogate marker, the ApoA1. And if that's not working the way that it should, you sort of say, maybe you don't have the protective effects of the HDL, or the theoretical protects of the HDL that you think that you have. Your fasting blood sugar, I didn't hear that. What was that?
97.
97? Okay. I think that's a great number too. For me, that may be a little bit on the high side. There is some data to say that maybe the A1C is not a perfect test for South Asians, and that having a fasting sugar more than 90 may be sort of indicative of precursors of diabetes or prediabetes. I think that that is all just diet and activity more than anything else. And it's not uncommon for me to have patients set up with our endocrinologist to at least have a conversation about the things that they're taking in. We have the advent of working with a endocrinologist here who is South Asian also, who will log the foods in the respective language of the patient that they're dealing with. So for our Gujarati friends, if they're eating jevdo and halwa in the morning and they're saying, oh, it's just a sweet snack, you sort of know what they're taking in. And mentally, in my head, I know that that's not the best thing to have with your chai. So it's not uncommon to get like a Dexcom or a glucometer to sort of say, what are the sugars doing throughout the day? And to your point with food logging is also, if I eat these foods, what is the sugar numbers doing? So that I can see where these numbers are at to try to keep those blood sugars a little bit lower. So we talked about the lipids, we talked about the diabetes. You have a great BMI. I think for me, an ideal BMI should be ideally closer to 23 for South Asians, is sort of what the WHO and some of the other, even the ADA has now come out with that sort of a statement. And that comes from sort of an extrapolation of data that if we compare, let's say you had two risk factors, hypertension and diabetes, and you had the BMI of 21, for example, that would be the equivalent of someone who is white with a BMI of 25. So you really want to try to get that BMI into the low 20s if possible. For women, they suggest even lower, like closer to 21, which I think is a difficult thing to do. I wonder if some of that data also sort of comes from the fact that what Romit had touched on earlier about the way we pack body fat into the abdomen, and so that sort of speaks to reducing organ level fat, and in a way reducing the risk of things like metabolic syndrome, higher inflammatory levels, risk of diabetes, insulin insensitivity, things like this nature. I think that from an activity standpoint, it sounds like you're staying as active as you can. And for me, I would also say that resistance training is equally important. I think there's a stigma to say, I'm just going to go for a walk, or I'm going to do sort of quote unquote zone 2 training. But I think the reality is that, especially for us as men, is that the testosterone levels start falling off a cliff, usually in your mid 40s, maybe even sooner. And so really what you're sort of setting yourself up for in the future is sarcopenia, which by itself can be a metabolic risk factor, knowing that muscle is going to get infiltrated with fat, and sort of leads to higher inflammatory levels, et cetera. So resistance training, I think, is important, along with the sort of routine low-level cardio that you may or may not be doing as well. I think sleep is equally as important. We're starting to find out a little bit more about that. So I don't know what you're an interventional cardiologist. I don't know if you're still taking call, but that can play a big role in cortisol levels, sleep cycles, and that certainly increases the risk of things like heart attack and stroke, sleep apnea, et cetera, which all play a role on the cardiovascular system, as we know. Diet standpoint, I guess, is the other thing. And you made a good point. I think there's this sort of stigma that it's all a vegetarian diet if you're South Asian, but in reality, the vegetables that we're eating are either fried or refined for the most part, depending on how you prepare them. So I think that also goes into what you were talking about, food blogging, and sort of saying what is the quality of the food that you're getting, and not necessarily what you're getting, and is also equally important.
Yeah. I think just to add on to that, Ankur, you're asking about the future, right? You're asking about the next 5 years, right? So I'm the assistant director of our cardiac lifestyle program at Mass General. So we focus a lot on the lifestyle foci. Now, in the classic cardiovascular case presentation, you presented everything as we would, right? You presented the lab results, the imaging results, and the anthropometrics. But what we didn't discuss are the most important things to prevent future disease. And this is a common problem in cardiology, not just South Asian cardiovascular disease, is that our prediction for young people, you're a very young person at 42, our prediction ability is very poor because we're measuring static variables in a dynamic process, right? So I would say that the most important thing, Jaideep had alluded to this earlier, some of the work that he and others, many groups have shown, is that when you have a CAC score of 0, which is the expected result for a 42-year-old, right? We should have a CAC score of 0, right? When we have that, the maintenance of that really depends on habits, right? And so I would say that we didn't mention your exercise routine, so I'm going to pretend that I don't know anything about your exercise routine or your diet or anything like that. And I'm going to say that those are the elements, right? The habits. I always say the life's essential 8, I divide them up into the 4 that are my problem and the 4 that are your problem when I talk to the patients, right? I say, great, I can keep your blood glucose normal. I can keep your blood pressure normal, right? I can probably give you a GLP now to keep your weight down, and I could probably give you Chantix to keep you from smoking, right? But there are a few things here that you're going to have to do, right? And this is on you, right? I always talk to them and I tell them, hey, listen, I'm like, just like you go to a financial advisor and you say, hey, I have this much income. This is how I want to retire. And they give you advice. That's who I am. I'm not the, you better do this or nothing. I'm giving you the best advice I can possibly give you, right? I'm an advisor to you, but it's you who's going to have to execute. So I would say that the most important things, I do not think that coronary calcification in all people is a inevitability. I think that there are definitely people who are prone to it. And I've seen very, very fit people. I've seen lots of, as we all have, with dense coronary calcium, right? We also know that there's that little paradox about exercise and coronary calcium. But I would say that reducing the risk factors up front and maintaining those habits, that's the important piece. The fact that your cholesterol is so low, untreated, that speaks of volumes. And I do think that you have a much, much, much better chance than average of not progressing with coronary calcium, because coronary calcium is ultimately the stabilized plaque that is already formed in those coronaries, right? So if your cholesterol has been lifelong that low for this long a time, we have a very good sense that that's going to be very good for you. So ultimately, I would say that your metrics are right where we want them. We want to keep them there, but it's the habits to maintain that over the next 30, 40, 50 years that are really going to keep the calcium at bay.
Yeah. So when you're talking to patients about habits, what habits do you want them to imbibe or inculcate in their routine if they're not in their routine already?
Yeah. Personally, I take this as a little bit of a personalized approach. What I find is that, we always talk about like the spiral of bad habits that will bring people down, but I really like to think about this as the spiral of good habits that bring people up. I think that there are usually one or two barriers to getting into that positive spiral of habits that people are often trying to overcome. Very often that's time with busy professionals. Very often that's sleep. Very often that might be, the responsibilities to a family or to elder care or things like that, work pressures. But whatever it is, there's often like one or two barriers that people have to jump over to get somewhere, right? Now, the habits that I try to impress upon people really depend on their risk factor. Almost always they're very similar, right? Almost always they're the life's essential 8. But what we choose to emphasize as the foundational habit, I think can really vary between people. So for instance, the patient who has prediabetes and has been edging towards diabetes over the last several years or months, right? The first habit I like to tell them about is walking after you eat, right? It totally inverts the physiology of your meal, right? You're not asking insulin to do all of the glucose disposal for you. You're saying, hey, guess what? Why don't my muscles kick in a little bit of effort there, right? Whereas the patient who maybe is very overweight, right? And we're talking about binge eating and we're talking about depression and isolation. Maybe the first intervention is something very different. It's about loneliness. It's about mental health, right? Maybe it's not starting to say, let's take away all these foods from you. Hey, what's going on in your life?
Yeah. And Jaideep, do you have anything to add to habits? I mean, what are some of the, you mentioned resistance training. And Romit mentioned walking after taking a meal. I think it's, going back to my teenage years and spent in India. That was something we would do routinely after having dinner is, just go out for a walk.
Yeah.
Evening walks are super common back home. But yeah, any habits you particularly try to impress upon your patients for them to imbibe in their routine for prevention?
Yeah, no, I second what Romit is saying here, because I think we sort of share parallel views of sort of how this works, where you try to identify what is the hardest for the person and then figure out a solution for them. Many of the South Asians that I see are sort of in just the location where we are, busy professionals. And so a lot of what I try to incorporate is like, you're trying to find time for yourself to do this, but in reality, what you should do is incorporate everyone into it so everyone's moving on the same page. That way you create sort of a household of, this is what we're going to do. So to your point there of after dinner, we're all going to go for a walk is definitely one way to do it. I have, guys with guys and girls with young kids, and it's like, play with your kids. You should enjoy and play sports with them and run around with them, because although it doesn't seem like a lot of exercise, there's the happy endorphins that come with that. And there's also the activity level that you're getting, even if it's some low level, you're not just sort of sitting on the couch after eating, for example. I like Romit's idea of the mental health thing. I haven't sort of had the opportunity to come across that in our practice just yet, but I think that's a really, really good statement that if you're going to identify people for what is going on, and it's a loneliness issue up front, then let's try to solve that first before we start picking away at other things.
Yeah, so I'm gonna ask you both. I mean, I'm sure you've had these conversations. I'm sure you've had these conversations with patients from our part of the world, or from our heritage or lineage or ancestry, however you want to call it. Um, and it's a struggle for me to talk to my parents about it. When we're talking about diet modification and patterns, because then they ask me, is like, then what do we eat? Like, what are we supposed to eat? We can't eat this and we can't eat that. What are we supposed to eat? um how do you ask patients from South Asian families to prepare a meal or to go about their food? Because carbs are sort of the foundation or the bedrock of each meal. I mean, whether it's bread or roti or rice. um and then you've got the veggies, and depends on, like you said earlier, how these veggies are cooked. I mean, if they're curries, then they're not the healthiest. um and then your starters are also like fried, like fritters and stuff, so with chai. So I mean, what do you do? Like, how do you recommend making dietary changes? Like, how does a South Asian plate look like, or a plate in a South Asian dinner look like, for example?
Yeah. No, I mean, that's a really, really tough question. And I think all of us have struggled with that conversation with our parents also. I know I did when I started. I guess the advent was, I grew up in Canada. And so there's also now abundance of different foods that you got to choose from outside of your own home. So it was never a situation where you're like, well, what are we going to eat? We can always have this instead of eating, food at home. For the patients that come into the clinic, I will usually take a food inventory and say, we're going to follow up, but maybe over the course of this next week, just give me a rundown of the things that on average you usually eat, and sort of make a running list of the things. More often than not, what I hear is breakfast is very, very light. Lunch is usually something pick up and grab on the go. And then dinner is the heaviest meal of the day. That's sort of what I hear when everyone's sort of around the table. Um, and that's, in a way dangerous too, because most of the eating is done at night, and then you're sitting down and then you're ready to go to bed, and your body doesn't get a chance to process all the calories that you've taken in now. So I try to get them to flip that on their head, which then relates to sort of the general lifestyle. Get a little bit more sleep, wake up earlier, make time for breakfast if you can. And the breakfast can be sort of what suits you best. But I do like to have them incorporate some level of protein. I haven't figured out a good diet for my outright vegetarians from a breakfast standpoint, because I think, there's still a thought that, I'll have some cereal, but that's still processed and packaged and more carbohydrate related more than anything else.
Yeah.
I let them enjoy their tea, things that are sort of normal for them. Maybe instead of putting whole milk, now you're putting 2% or skim milk. And that takes a mindset to switch. But I think you sort of get used to it. After a while, it's like if you don't eat anything very salty for a long time, then you have something salty, you're like, wow, this is really salty. So I think it's the same idea that you sort of get accustomed to that level of taste. I think with the dinner meals, usually what I recommend is, instead of frying, is a pressure cooking is a good way to get around that. Or crock pot cooking is another way to get around that, so that you're not sort of deep frying or sauteing a lot in a lot of oils as well. I think that the lentils, the dals, the rajmas, all of that stuff works well from a protein standpoint. It's just if you're trying to meet quote unquote protein goals, you've got to have a little bit more of it. And I always recommend some sort of leafy green on the plate as well to aid with digestion, usually before to help curb some of the blood sugar levels before the actual meal. Romit, I don't know what you guys are doing or recommending for your patients.
Yeah, I think that ultimately I recommend things that are pretty much in line with the other dietary, the studied diets, right? So the Mediterranean diet, the DASH diet, the alternative healthy eating index, right? Which, some recent analyses have once again shown that it doesn't matter which diet you choose, the higher the fresh fruits and vegetables, the higher the whole grains, the higher the nuts, legumes, seeds, the better off you are in terms of brain health, longevity, cardiovascular health, and a whole host of other markers. There's some interesting work being done out of AIMS in New Delhi, that's adapting the Indian diet, North Indian diet, to the Mediterranean recommendations. There's some interesting work being done out of Stanford, out of the Nourish project there, that's adapting South Asian cooking to be adherent to both the AHA and ADA guidelines. Um, Ultimately, these are not big changes, but they do require a couple of things. One, curiosity and willingness to be flexible on the part of the patient, which I think is sort of ground stakes for lifestyle change. Um, the second thing is that it does require a little bit of sacrifice, of understanding that samosas are not an everyday food, right? Having pakoras it's not an everyday food, right?
Mhm.
Having sweets after dinner, it's not an everyday food. And also, like, our ancestors got the way they were, healthy and lean and living to 90 by a lot of activity. They were walking to the market every day. They were going around. They were walking to their work. They were the activity, and also they were hungry part of the day. And so I remind people that also it's not evil to be hungry some of the time, right? We don't need to have snacks, every hour. So I think that those two things, I think, are so uncomfortable for the modern human, not just the modern South Asian, but the modern human, is to be active, and sometimes it's okay to be hungry. It's okay to anticipate dinner. "Oh, I'm so ready for dinner," right? It's okay to feel that way, and I fully agree with you, Jaideep, about, like, sort of, like, moving that end of the day load of food earlier. I think that's really important, and eating everything in smaller quantities, and then making sure that we have fresh fruits and vegetables as half the plate, right? Like, that plate method really does work, right? And we so rarely have fresh fruits and vegetables. Like, salad is not really that much of a thing. Like a cucumber salad or something, fine, maybe, but, like, salad is not really that much of a thing in South Asian culture. So we take all of our vegetables, we put them in oil, we put them in something else to do some sort of flavoring to them. But I think that encouraging families to say, hey, you can eat all the traditional foods. Just add in the fresh fruits and vegetables, add in the whole grains, add in the Greek yogurt, whatever it is that is the missing dietary element in their particular pattern.
Yes, and I think this is something which has come up. I've been asked about this repeatedly. When I go to family gatherings and weddings in particular. Is like, is there a particular oil that we should use to cook? And is it that the oil that we're using, the vegetable oils, versus now the compressed oils which are available? I mean, they're costlier, but are they healthier? What is your take on that for South Asian cooking? Is there a particular oil? Because we cook at extreme temperatures, so I'm not sure if olive oil at extreme temperatures remains as healthy. So what is your take on that? And has that come up during conversations with patients?
That certainly comes up all the time for me. Um, I would say that number one, frying is not a great way to cook, right? So I'd say that, like, if we're going to be frying our food in oil, there is a cost to that from a health perspective. But if we are frying, there's probably things that we can do around the edges, right? Polyunsaturated fats are way better than saturated fats. I'd say that your canola or your peanut or avocado oils, these are higher tempered smoke point oils that are probably a little healthier. But ultimately, I think that it's hard to get away from the fact that frying is a bad way to cook.
In general, like frying is probably just not a good idea. And that I think speaks to what he was talking about earlier, where Having 5 fruit every day shouldn't be the standard sort of expectation. I think that you really want to focus on sort of a plant forward, and with obviously the protein sort of intake as well. I think when it comes to the oil portion of this, I know, like, for example, at least, at least some of the best nutritionists we work with South Asian patients will tell you really want to avoid hydrogenated cooking oils that you use for things like samosa or kachoris. Uh, the other thing that I've seen is that people will save the oil, so you really don't want to reheat the cooking oil that was already once used. That is dangerous as well. In terms of like high heat cooking, I've heard canola, avocado is maybe a better choice. Palm oil, I think olive oil, like you said, is good, but not necessarily for dishes that require high cooking. And maybe that answers your questions a little bit better. I'm not necessarily sold on the ghee or butter thing either. I think that's a great fad that has taken off and people are making a lot of money off of. But that is a very dangerous habit.
Yeah. What do you think about clarified butter? I mean, what do you think about ghee, which I know is integral to so many North Indian homes? What is your take on that as someone who's seen and talking to these patients about clarified butter? It's sort
Yeah.
of become, I don't want to say fashion, but maybe it's become fashion in North America now. What do you have to say to that?
Yeah. I mean, you walk down any grocery store, you'll see flavored ghee or different types all selling for like $16.99. Versus you go to an Indian store and it's $2. I think ghee is probably more of a remnant of what we were doing before. It's probably more of a preservation method, and then obviously used in cooking.
Yeah.
I think what hasn't changed is that is a dangerous thing to cook with, just because of the risk of fat accumulation and fat deposition and risk of coronary disease and things of that nature. And I frequently will tell patients it's probably best to avoid it if you can. I understand there are certain, festivals and cultural things where events where this will get incorporated. But maybe again, back to the original point, is this shouldn't be sort of an everyday cooking, used for a cooking modality, if you will.
Yeah, I fully agree. I mean, I don't like to take things away that are joyous, that bring joy to people. I always tell people preventive cardiology should be an expansive field. The goal is not that we're taking things away, but it's that you're to have a bigger life for longer. You're going to be able to play with your grandkids. You want to be able to like walk up Machu Picchu with them, like whatever it is, you want to be able to retire someday, enjoy that with functionality, right? And what we've been seeing a lot is we've been seeing South Asian elders are aging more poorly than elders of other ethnicities within the United States. We see that certainly in India. One of the news articles I saw a while back was covering the number of wheelchairs used in the airports in India for South Asian elders. Are all of them disabled? No, but they do feel uncomfortable and frightened to get through a line or a crowd, to stand on a line for a period of time, right? And so that speaks to a level of disability. And I believe that there's a longitudinal study of aging in India, centered in Delhi, that has demonstrated this increase in disability above the age of 60, which is such a young age, right? And so when I think about how are we going to strategically deploy our lifestyle interventions, I talk a little bit about this, that what's the goal? The goal is this beautiful life, right? Where we aren't living the last 20 or 30 years of our life with the world slowly shrinking around us. We're living it with expansion, with joy. And so part of that is a little bit of restriction on the front end. And we all understand this in terms of saving for our financial future, for instance. We say, hey, listen, we're not going to buy a Benz today, so that I'm going to put that money in my retirement account. And someday I'm going to take it out and I'm going to live happily retired, right? but somehow we have a hard time investing in our health the same way. So I think the question of ghee, I went off on a little tangent there, but like the question of ghee is exactly like that. It's a delicious thing. I love ice cream, right? I love ice cream. Man, if I could eat ice cream every 3 times a day, I would eat it, but I can't, right? I will drop dead very quickly. So ghee is the same thing. Delicious thing, pretty bad for you. Have it a little bit once in a while. That's it.
Yeah, no, I mean, we're on top of the hour, and it's a sort of was like drinking from the fire hose. You guys are just amazing in knowledge base, and the amount of literature that you had to share, both of you, was incredible. So thank you so much for doing this for us. I think we should do a part two. You have to come up with a list of what I have not touched upon. I'm sure there are other avenues where we can talk more. But it's been fantastic having you both. Any closing remarks for our audience who have tuned in to listen to this episode? And for those of you listening, thank you for tuning in another Monday. Share your feedback with us. If you have questions for Romit and Jaideep, please, you can email them directly. We'll have their email address in the show notes. You can email them to us and we can forward those questions to them. I'll start with you, Jaideep. Any closing remarks for this episode and for Parallax?
I just want to thank you again for the opportunities for us to spread the word about South Asian health. It feels like there are a lot of us, and there are, but we are still a minority population, at least in North America. And so the work that we're doing is only possible if awareness is raised for it. Like many of my patients that come in and are first time on, so don't know what to expect with coming to a specialty clinic. I think the biggest thing is to know your numbers, to be screened, to be checked, be aware. That is the strongest thing and the greatest thing that you can do for yourself. You want to bear witness to what is going on. You don't want to be left behind and then wonder, oh, I wonder why that happened. I was doing great. We always hear the story. He was fine until he wasn't. She was doing fantastic. And then all of a sudden this happened. So I think knowing your numbers, improving sort of your knowledge base about this makes you a greater advocate for yourself and the people that you love. And I would highly recommend that to everyone.
Thank you so much, Ankur, for having us on. I'd like to echo Jaideep. In terms of the few takeaways that I'd like people to have, the first is that a pound of prevention is truly worth a pound. Ounce of prevention is truly worth a pound of cure. What we're seeing repeatedly in metabolic disease is that you require just small tweaks to prevent disease, but huge effort to reverse it. So to be to be proactive in our approach to preventing disease is an incredibly powerful tool. To that end, I think exactly what Jaideep said about screenings, and that extends beyond cardiovascular screenings. I see so many South Asian individuals who aren't getting their colonoscopies or their mammographies because it's inconvenient. People are busy, I get it. But we have to do our screenings, or else these preventable diseases that ultimately end life early, we miss opportunities to intervene. And the third thing is to say that, yes, it is true when we're looking at others around us. Sometimes it feels like we have a higher propensity to develop these risk factors in this disease. You eat a little bit off and you gain weight. You develop high blood pressure with no effort. Your cholesterol's just been high your whole life. But genetics are not destiny. And it is very important to know that those who are at the highest risk, they benefit the most from doing the smallest tweaks. And it may feel like that's just putting a finger in the dam, but it's not. It's a huge investment as long as you do it longitudinally over time. So those are the things that I would really emphasize would be sort of saying that prevention is so important. Screening is the first step in prevention, and your genes are not your destiny. You're able to overcome this.
Yeah, no, excellent, excellent summary to end the episode. And thanks again for both of you, and thank you all for tuning in. Until other Monday, we'll see you next time.
Fantastic. Thank you so much.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.